Hello, everyone. Welcome to RegenMed Global, the podcast, where we bring you the newest breakthroughs in medicine and research to help bring hope in fighting incurable diseases. My name is Shayan. Today, we're here to discuss a clinical trial using stem cell transplantation for metabolic disorders. Leading this research, we have Dr. Paul Orchard with us. Before we get started, can you maybe just tell us a little bit about kind of what you do?
Sure. So I'm a pediatrician. I was trained additionally in hematology, oncology, blood and marrow transplantation. And primarily my focus has been blood and marrow transplant field. And then especially over the last 15 to 20 years, I've been very interested in the use of blood stem cell transplantation for non-malignant conditions. So a lot of the things we do with blood stem cell transplant is treat patients with leukemias, for instance, and other types of cancers. But I've been more interested in the non-malignant population, especially those that have rare inherited disorders. And some of those are lysosomal, some of those are peroxisomal. There's different aspects of the cell that are involved. But there's an opportunity to treat some of those patients with transplant, and so that's what I've been interested in, really focused on.
Can you tell us a little bit about about the stem cells being used within this research?
Sure. So stem cells refers to the very early cells that could grow up and be a much more mature population of cells. And so we threw on the term hematopoietic, which basically means blood cells. So we're talking about the blood stem cell population and or bone marrow, which is where those cells are primarily located. So that's the population of cells that grows up and they can develop the immune system. There's white blood cells that are parts of the immune system. There's platelets that help you to not bleed. There's red cells that carry the oxygen around and get rid of the CO2. And all those cells come from the hematopoietic stem cells. So when we do the transplants, we want the very early population that can grow up and provide all those aspects of the blood, essentially.
Okay, so are these stem cells derived from the patient or are they derived elsewhere?
Well, so there's a couple different ways to get the cells. Again, most of those blood stem cells live actually in the bone marrow. So, if you were to, for instance, break a chicken bone, the outside of the bone is dense and hard, and then in the middle it looks almost like a honeycomb, and that's where all the cells that are the blood producing cells live, essentially. So the very early cells are there, and as those cells mature, then they move into the bloodstream and populate the blood. But if we're going after the cells that are very early cells that can produce more blood cells for the rest of someone's life, we want those early stem cells, those hematopoietic stem cells.
Okay.
So ordinarily, if we're trying to access those cells, we get them out of the marrow, although there are some methods now to treat patients that releases those cells into the bloodstream so you can actually access them that way.
Can you tell us a little bit about the clinical trial, just like an overview?
Well, so maybe we'll kind of go back a little bit to the beginning. Why would one consider using blood stem cell transplantation for these rare diseases, like these enzyme deficiencies, for instance?
Okay.
And this goes back to the late 60s, when people figured out that there are some cells that were derived from kids that had these rare disorders. They were enzyme deficiencies. They didn't necessarily know exactly what those enzymes were at that point. But they showed if you took those cells in a petri plate in tissue culture, those cells would accumulate storage material or substrate that ordinarily those enzymes would break down. And the lysosome is a little organelle inside the cell where a lot of these things are supposed to they localize to, and they're supposed to be degraded, and then the cell can get rid of them. And if you don't have these enzymes, that backs up, essentially. So kind of depending on which disease you're talking about, it's got a different enzyme. The material that backs up is a little bit different. But those are the things that end up causing the manifestations of the disease. So, but the group back in, again, the 1960s showed that if you took normal cells, put them in the same petri plate with the cells that were accumulating all the substrate, that substrate went away. And so they turned that cross correction, meaning that the the normal cells can correct the cells that have these deficits, enzyme deficiencies in that case. And so that led people to say, well, if that's true, can we establish blood cells from someone who doesn't have this disease, whatever that disease is, in a patient that's got this enzyme deficiency, and will those blood cells circulate through the body essentially for the life of the patient and serve as a source of enzyme that can treat the disease? So that initially got started back late 70s, early 80s, and people started looking at transplant in that venue, and then explored for a number of different diseases whether transplant seemed like it would help. So that's really kind of where things got started. And then over that period of next 10, 15, 20 years, a lot of these disorders, and again, these are virtually all very rare disorders, people help understand what the role of transplant was in treating these things. So we've got a pretty good idea for which diseases does transplant work and which diseases doesn't it work so well. And then we're interested in other methodologies we might be able to do to get better outcomes for these patients. So this has been an ongoing line of investigation for a generation, essentially.
How long has this clinical trial been active for?
So this one's been open about 10 years. So in terms of blood stem cell transplantation, again, it was primarily used for treating patients that have malignancies like leukemias. And so essentially, those are cancers of the bone marrow, essentially. And if you can use somebody else's healthy bone marrow and replace the person's marrow, the person that has the leukemia, replace it with a healthy marrow, that's a means of effectively treating the disease. So there were chemotherapy regimens that were developed to accomplish that. So essentially there's two things they're trying to do. One was to establish a new healthy bone marrow in the person who's affected by leukemia, for instance. And then the other would be to try to eliminate as much leukemia as you can with the chemotherapy. And so that was kind of the package that's been developed. Initially, when we started using transplantation for these kinds of rare diseases, we borrowed from that experience and used those kind of chemotherapy regimens, which are pretty intense because we're trying to, again, cure cancer in these patients. And we use that for these rare disorders. But you still need, for the rare disorders, to establish a normal blood cell population derived from some healthy donor, but you don't have to get rid of cancer in those patients. And so you may not need the same intensity of chemotherapy as that you would otherwise need if you were trying to cure leukemia. So that's part of what this protocol is say this is a protocol specific for patients that have these rare enzyme deficiencies or peroxisomal disorders. And here we don't worry about curing cancer. We just want to get the normal cells to establish themselves in the affected patient and stay there. And so all the blood-producing cells later are going to have the availability to provide enzyme to this affected patient. So over time, we've been modifying our treatment regimen in an attempt to kind of thread that needle, to be able to back off on the intensity of the chemotherapy such that we don't make people any sicker than we need to, and still get to the goal of having a long-standing blood-producing cell population that's derived from someone else who's healthy.
Can you tell us a little bit kind of just like how the procedure looks like and how long someone would go through this treatment? Sure.
So for instance, there's patients that, and I'm a pediatrician, so there's mostly patients with that are young that we're considering for these protocols, and not exclusively, but generally. So some of these kids may be a year of age, a couple of years of age.
Wow.
If we make a diagnosis that they have one of these disorders that are basically genetic diseases that are otherwise incurable, and they need to get a transplant, one of the first things that we have to do is help identify a healthy donor. So there are markers on our cells, our red cells and platelets and white blood cells, that designate those cells as being yours. And so that what we call HLA typing is associated especially with the white cells and platelets, for instance. But in order to be able to minimize the risks associated with transplant, we want to find a donor that's got an HLA type that's well matched to the person that's going to get transplanted. So there's a couple different methodologies we use for that. Any full sibling from the same mom and dad would have a 1 in 4 chance of being a match. So a lot of times if there's brothers or sisters, we would look in the family to see if there's somebody that may be well matched. In this circumstance, we're worried about these rare inherited disorders, so we'd want to make sure that a matched brother or sister didn't also have the same problem. And they could be carriers of the disease too, in which case they may have one set of genes that is not producing enzyme very well, and so they may have half as much enzyme to deliver. So that's kind of an issue. But ordinarily, one of the first things we have to do to consider transplant is to find a donor. If there aren't any donors within the family, then we can look outside the family. So there's a group that's called Be the Match, or the National Marrow Donor Program, that have databases of millions of people that have been HLA typed, and we can go to them and say, this is the HLA type of my patient. Do you have someone in your database that matches this person? And they will electronically provide the closest matches to us, and then we would help make a decision about what the best opportunity is to treat that patient. So for those adults, so these are people that may be within the U.S., they may be in Europe, they may be in Asia, they could potentially be anywhere. We need to reach out to those patients, and that's done actually through the national through the NMDP, the National Marrow Donor Program. So they contact an institution close by where that person is, the donor would be, and say, look, you're a potential match for someone who needs a transplant. Would you consider doing this? Generally, they would say yes. They come in, they have blood drawn. We take another look at the HLA type just to make sure that it is what we think it is, just to confirm that. And then we would have an assessment done by the donor, make sure the donor is healthy and there's no potential issues there. And then we would set up a time for the donor to provide the stem cells. So, because we have to work around the donor's schedule, because they do this out of the goodness of their heart, essentially. They don't get paid to do this in any way, shape, or form. So we would work around the donor's timing and say, establish a date where they could have their marrow harvested, for instance. And then we would figure out from that when the patient would need to come in, the patient's going to get treated, when they would need to come in and have the chemotherapy that's prior to the infusion of the cells. And then the cells would get shipped to us from wherever the donor might be, and they're actually infused here in the hospital. Those cells actually just go in intravenously. They don't need to be put into the bone marrow. They circulate through the blood. They find their way into the marrow. They establish themselves there, and they start to grow and proliferate. But it takes a while for those cells to grow up. And in that interim, the patient getting transplanted has virtually no immune system, and there's a likelihood of infectious complications. We could support them with red cells and platelets so they don't have bleeding complications, for instance, but it's a difficult process. The patients are in the hospital for 6 weeks at a time, if not longer. Families, most of the patients that we treat are not local patients. They come from all over the country, if even internationally. So the families are pretty much uprooted for a matter of months. We would ask the families to stay locally for at least 100 days after transplant, So the families are here for an extended period of time, and again, it's very disruptive. And sometimes these kids are very sick and in the hospital for a long time, and the complications of transplants are such that we still lose patients going through transplant. We can have immunologic complications or bad infectious complications that can be life-threatening. So it's a really difficult process, but the concept of this protocol is to help refine that process as best we can to minimize the complications of having to go through the transplant.
What are some of the results that you've seen out of this clinical trial?
Well, so there's a couple different ways we look at things. One is how successful are we in getting the patients through the process? I mean, what's the mortality rate of going through a transplant like this? And, historically, that's been an extremely difficult thing, a challenging thing to do. As we've gotten more access to better donors, and as we've been more sophisticated in fine-tuning our chemotherapy, the mortality rate has dropped. And generally speaking, it may be in the 10% range or 15% range, so it's still a significant issue, but it was much higher before. So getting someone through the transplant, documenting that the blood cells in circulation after the transplant are all donor-derived. That's really what we're attempting to do with the transplant. If we're going to try to deliver enzyme from a healthy person, if the donor cells don't take, for instance, then you're right back where you started from. So you have to kind of get the kids through the process, hopefully ensure that they have donor-derived cells at the end of this. And so there's the outcomes that we look at in terms of just what's the success of getting through the transplant with minimal complications. And then there's the aspects of the various diseases. So there's a number of disorders that this protocol is open to that are these rare types of diseases. And different diseases have different disease-related complications. Some of those may be cardiac or skeletal or neurologic, for instance. And so that's another important piece is how are these patients doing related to their disease after transplant, and what would we expect that natural history to look like if they hadn't gone through the transplant? How successful are we at actually treating their disease is a key aspect of things.
Do you have like an example of a patient maybe that you guys have treated and you guys have seen great results from, or just generally speaking, can you share with us a little bit about the type of results in terms of the quality or improvement of their diseases?
Sure. So one of the disorders that we see a lot of is a disorder called adrenoleukodystrophy. So adrenoleukodystrophy is it's a peroxisomal disorder. The peroxisome is one of these organelles that is present in the cell. It's inherited, it's X-linked, and so that means that it's essentially just boys that are affected with this disease. Mm-hmm. And when these boys are born, they look absolutely fine. They don't have any manifestations of the disease. You would never know that they have adrenoleukodystrophy. But about 40% of the boys up until the age of 18 develop a neurologic aspect to their disease. It's an inflammation that's present in the brain. It progresses, it's debilitating, and it's lethal. I mean, these kids die of this. So it was back in the 90s when they first started using transplantation for adrenoleukodystrophy. One of the things we can follow is what do their MRIs look like, because it's a white matter disease. It changes the myelin in the brain. The myelin is kind of wraps the nerves like insulation wraps a wire. And if the myelin goes away, it really affects the nerve function. So one of the aspects of the disease is what does the MRI look like? That's relatively straightforward to follow. But if we catch these patients early and can intervene early with transplant, it generally stops progression of their disease. If it's more advanced, if the patients come to us with more extensive disease, it's much harder to stop the disease and minimize the aspects of what's happening with that neuroinflammatory process. So one of the things that's been really important for us and on the field is this is now being screened as a newborn screening entity. So, when babies are born, before they leave the hospital, they do a heel prick, and they take a few drops of blood and put it on a card called a Guthrie card. And then those drops of blood can be screened for a number of different diseases. So adrenoleukodystrophy is now on that list of diseases to potentially be screened. Each state decides which diseases they're going to screen for. So I think it's about 40 states are now screening for adrenoleukodystrophy, but that means you can identify these boys essentially at birth. And then we can follow them along, and if it looks like they're starting to develop this neurologic aspect of the disease, we can intervene very early and minimize the risk of progression to the point where they may have lifelong disabilities. So that's really been an important development in the field, and something we're very excited about.
Wow. So basically you're saying this can pretty much halt the disease progression of individuals with that particular disease. Is that right?
Right. Yeah. So if you, again, if you follow these kids along, the natural history of the disease is that white matter involvement with the neuroinflammation tends to spread progressively. And it generally is located in the back of the brain. And that's where you interpret your vision. Your eyes are fine, but as you develop more white matter disease there, it interferes with your vision. It also interferes with your hearing, because as a spoken word, you have to decipher within your brain. Again, your ears are fine, but interpreting the word or a sentence or whatever, that's done in the back part of your brain. And if that progresses to the point that it's affecting your hearing or affecting your vision, those things are irreversible. So we don't have a way of restoring that function. So it's really key for this disease, for instance, to intervene early so you don't get to the point where you've lost a lot of that function, because you'll never regain it.
Just with stem cell transplantation itself and with these inherited metabolic disorders, why would you say this clinical trial is so important, and what kind of impact can this have on the future of medicine?
Well, so there's a number of aspects of things that we're looking at. So, again, the complications associated with the procedure is some of the things that we're really trying to minimize, but we're trying to best understand how these applications for these diseases, how effective those really are, and whether there's other things that we can do to potentially modify how these patients are doing. But one of the big aspects of this clinical trial is we've done a number of modifications of the chemotherapy regimen, trying to minimize the untoward effects of the chemotherapy, for instance, and get these kids through the trial more safely, easier, and with less time in the hospital. So that's really been the focus. We're also quite interested too, and this is beyond the aspect of this current trial, but I think one of the places the future is going to go, and we're doing other trials in this regard, is whether gene therapy will be an alternative to standard transplantation. And in that circumstance, you could potentially take the kid's own bone marrow, and we have ways of isolating those cells, and then engineering the cells to make their own source of enzyme. So rather than using somebody else's cells that we have to worry about immunologic related complications, and patients are on immune suppression for an extended period of time, for instance, if you get your own cells back, it's a much easier process on the kids. And so that's one of the things, again, not part of this trial, but that's one of the things we're very interested in looking at too. And then we want to be able to compare the experience on our current trial with the outcomes of these other approaches, these gene therapy approaches. So that's something we're really excited about as well.
Let's say someone's watching this video, maybe they can relate or maybe know somebody with an inherited metabolic disorder. I mean, who would you consider to be like an eligible or ideal candidate for this clinical trial?
Well, so some of that depends a bit on which disease we're talking about, because a lot of these disorders are progressive issues, and if they get to the point where the individual patients have already lost a lot of function, then they're going to not have as good an outcome with transplantation. So I think that's one of the key aspects of things. So based on whatever the disease is, and again, this kind of gets back to the newborn screening piece, but a lot of the patients aren't picked up and a diagnosis established until they've already had significant problems. Mm-hmm. And for some of these patients, it takes a long time, and you have some experience with this as well, but the diagnostic odyssey of these patients can be long and drawn out. You may have to go to a number of different people to have somebody do the right tests to make establish what the disease actually is. And the longer that takes and the more aspects of the disease become apparent, the harder it is to effectively intervene. So it's much easier to stop complications from happening than it is to reverse them once they've already been experienced, because a lot of these things we don't have a great way of reversing. So that's one of the key aspects of if we're looking at candidate patients, how far along is the disease? It ends up being an important question.
Okay, that makes sense.
So that's one of the things and a lot of times we can't really establish that unless we have the opportunity to see the patient and do imaging or to do cognitive testing or developmental testing, and have them see our group and the neurologists and potentially ophthalmologists and cardiologists and all the rest of our colleagues to better understand for a particular patient how effective the intervention might be and what the risks are of proceeding.
Dr. Orchard, is there anything else that you'd like to go and add, or any other final thoughts?
Well, so if there are people that are interested in exploring this, for instance, we're happy to consider patients that might benefit. So if there's groups out there that would like to contact us and think that they may have things that are disorders that we may be able to impact, then we'd be more than happy to see what we can do.
Dr. Orchard, thank you so much for all your information. This has been very helpful.
Thank you, Shannon. I appreciate the opportunity to talk with you.